A patient presents with dizziness, gaze instability, and angina-like chest pain. You run the standard cardiac workup. Normal. You check vestibular function. Normal. The symptoms are severe, but the primary organs show zero structural defects. The true origin of the symptom triad often resides in the neck, specifically cervicogenic dizziness, driven by upper cervical dysfunction or spondylosis. This condition operates as a unified neurophysiological cascade, where mechanical pathology in the cervical spine corrupts the data streams required by the visual and cardiovascular systems. The cascade begins when altered cervical afference generates a somatosensory mismatch. Neck receptors transmit a head position conflicting with data from the eyes and inner ear. The brain's attempt to resolve this conflict dysregulates oculomotor reflexes and sympathetic autonomic outflow. Guidelines from the Academy of Neurologic Physical Therapy define cervicogenic dizziness strictly as a diagnosis of exclusion. Other pathologies must be systematically ruled out. The clinical examination must include a focused assessment of oculomotor function and cervical range of motion. Resolving this treatment-resistant triad requires tracing the neurological pathway from the cervical joint directly into the autonomic nervous system. Normal postural control depends on the flawless integration of three inputs: visual field data, vestibular signals from the inner ear, and cervical proprioception. The upper cervical spine, specifically C1 through C3, serves as the primary hardware for head-on neck orientation. To maintain spatial awareness, this region utilizes an exceptionally high density of muscle spindles and joint mechanoreceptors. In a healthy state, this sensory data travels via the dorsal root ganglion to the central cervical nucleus and up into the vestibular nuclei. This sensory hardware fails when confronted with mechanical pathologies like cervical spondylosis, trauma, or chronic postural strain. Structural degradation in the discs and facet joints physically alters the environment of these receptors, distorting the local anatomy. This damage triggers the proliferation and ingrowth of nociceptive pain receptors directly into the degenerating tissues. Simultaneously, the surrounding muscles enter a state of chronic spasm and fatigue, which distorts the sensitivity of the local muscle spindles. The combined result is a proprioceptive signal that is chaotic, erratic, and heavily corrupted by pain. The brain is now operating on corrupted GPS data from the neck, attempting to navigate using a sensory map that no longer matches the inputs from the eyes or the inner ear. Within the brainstem, the vestibular nuclei are forced to process smooth data from the eyes and inner ear alongside an erratic line of data from the neck. The brain attempts to resolve this conflict through central sensory reweighting, filtering the corrupted cervical signals while amplifying other inputs. Under normal conditions, the vestibulo-ocular reflex, or VOR, is the primary system responsible for stabilizing your gaze during movement. It is supported by the cervico-ocular reflex, or COR, a secondary system that stabilizes the eyes based on neck movement. These reflexes normally function at a balanced equilibrium, effectively splitting the workload of gaze stabilization. But as neck mobility decreases and cervical signals become erratic, the scale tips. The brain is forced to pathologically upregulate the COR to compensate for the failing inputs. This creates a severe lack of synergy. The VOR and the hyperactive COR begin to operate out of sync. The resulting feedback loop manifests as visual dependency and jerky tracking movements, such as corrective saccades and nystagmus. These oculomotor errors are the direct source of the lightheadedness and unsteadiness reported during head movements. In this state, the visual system attempts to compensate for the failing cervical sensors, but the resulting mismatch creates the persistent sensation of dizziness. Beyond spatial disorientation, this sensory mismatch triggers a systemic autonomic fallout. The overstimulated vestibular nuclei project signals directly into the reticular formation and the parabrachial nucleus. The signal then descends the spinal cord, moving into the thoracic region. Here, the descending tracts target the sympathetic preganglionic neurons. This anatomical circuit constitutes the vestibulo-sympathetic reflex pathway. The chronic sensory mismatch in the brainstem keeps this reflex pathway in a state of abnormal activation, flooding the system with unwarranted stress signals. This forces the patient into a state of sympathetic dominance, a chronic systemic fight-or-flight response. This dominance explains the clinical presence of cervicocardiac angina, sudden palpitations, and altered heart rate variability. The chest pain and hypervigilance are genuine physiological events, driven by a neurological panic alarm originating in the neck. Because this condition is both mechanical and neurological, effective management requires a strict two-pronged approach. The first prong is mechanical intervention, restoring normative afferent inclig at the source. Mobilizations, traction, and sustained mechanical glides are used to quiet the nociceptive firing in the facet joints. Correcting postural louds like upper crossed syndrome is necessary to permanently reduce muscle spasm and spindle distortion. The second prong is sensory motor and vestibular recalibration, designed to correct the brain's processing errors. Laser head tracking, gaze stabilization, and dynamic balance exercises force the brain to relearn accurate proprioception and restore VOR-COR synergy. Clinical evidence strongly supports this combination of therapies, addressing both the peripheral neck dysfunction and the central vestibular mismatch. Resolution occurs only when the treatment addresses both the mechanical hardware of the cervical spine and the neurological software of the brainstem. By treating this unified neurophysiological cascade, we can stop managing isolated symptoms and finally resolve the interconnected triad of dizziness, visual disturbance, and pseudoangina.